Let's see. So again, like I said, welcome. My name is Brianna Lafayette Brooks, and I am with Capital City Nurses. And we've been around for 45 years, and we do a lot of community involvement with personal care. We work with a lot of geriatric and assisted living facilities in the area, in the Northern Virginia, Maryland, DC area. And we also are in Delaware. And we want to welcome you to this great series of Let's Chat with Dr. Ernest Brown. And he is, just so you know a little bit more about Dr. Brown, if you've never visited before, he is a wonderful sir, concierge medicine. He started Doctors to You, which is, kind of going back to the old school. Doctor knocks on your door, and there you are with the little black bag. And he's here with us today to talk a lot about his experience with COVID-19, where we're going with it, and what's kind of coming on the horizon. And before I turn it over to you, Dr. Brown, just want to remind everyone, we're just going to keep everyone on mute and keep your cameras off. And then if you have a question as we listen to Dr. Brown speak, go ahead and put it in the chat, and we will do a question and answer at the end of our talk today. So welcome again, everyone. And Dr. Brown, I will turn it over to you.
Excellent. Well, thank you so much. And it is a beautiful day out. So hopefully we'll do this and everybody can get out and stretch a little bit. This talk, I do like it to be an opportunity to open up the floor. So certainly putting any questions or even subjects that you might want to have some discussion about, certainly share that in the chat, and we'll get to that. I like to talk, so I will do that. And but that doesn't mean I can't pause and shift directions if there are any questions while you got me right now. The discussion in this case is, about the current status for COVID-19 in the Washington, D.C. area and internationally, and it has relevance to what we experienced over this winter. Last spring, when we were starting to receive the vaccines, and I was telling that this winter was the winter that was going to determine the success of those vaccination strategies, short-term and long-term, and also what we're going to need to do to continue to be prepared for COVID-19 as it shifts from pandemic to endemic. We are in a situation right now where we have already seen what effect a variant can do, and the dynamics of that most recent variant and how it compares to what we've seen. What we are experiencing is essentially the evolution of a virus. And we are seeing this on a global scale because we are now a global community. And this has always been part of the discussions in terms of pandemics. When we go back in time, this is just kind of renewing what we had in the past with MERS, or Middle Eastern syncytial virus, and then also with SARS. Now it is SARS-CoV-19, and where we will be in the future. This is not unlike what we were not hoping for, but we suspected could happen. And we are seeing this continue to evolve. When we look at COVID-19 or any virus, they're perfect little coding machines. And as they continue to evolve, they'll pick up things, get information from other sources, or adapt, or simply by raw shotgun effect, it will figure out and a new variant will pop up. And in particular, when we go back to Omicron. So Omicron, our first cases in the Washington, D.C. area, particularly came from international travelers. And that's important because this is where we also need to consider our global community in the Washington, D.C. area, and what we are doing to kind of monitor these things and testing strategies, and how we have to evolve as the virus evolves. So when we step back in time, the first, what happens, scientists and physicians working across different organizations are constantly looking at the spread of the virus, but more importantly, the genetic material. The genetic material is how we are performing our testing. We're taking certain sequences, and that's how we can test for the virus. But then when we sequence the virus, we can also check to see if there are mutations. These mutations are what are the variants. The virus over time, just like influenza, will change slightly. And it's a question of, is that change significant enough to have an impact? And I would say this, that any variant has the possibility of going in, just kind of staying the same, making the virus more virulent or less virulent. And what we have seen with the most recent variant, unfortunately, was that transmission was extremely fast, and the mechanism of that transmission was maybe somewhat different in that the virus is shown to be more resilient to staying on surfaces longer. And so even when we shifted from Delta, where people were using masks, when Omicron started to come, I was advising parties and groups that I've consulted with that in addition to mask, a glove was extremely important. And the reason for that is because the virus is adapting. Now, that doesn't mean that it's going to adapt into a superbug. We think that right now, especially what we've been seeing recently, is that this will eventually settle from a pandemic into an endemic, and will, similar to influenza. That means that every year we will have new strategies. And these strategies, of course, are in terms of medications, antivirals, but also, more importantly, preventatives like the vaccines. We can easily show for COVID-19 the vaccination strategies that were employed early on, and the results. If we had not had the vaccines with this most recent outbreak of this Omicron variant, we would have seen a very dramatic difference in terms of hospitalizations and death rates. Because the transmissions were so fast, it actually was the worst case scenario. Just to think that we got the vaccines just in time to be able to be prepared for this, it should be a sign that we're doing what we need to do, and that there is a hope for being able to change this tide, because we know it's going to be here for some time. It's not going to just magically disappear, but we do have, and we are continuing to work on strategies to muscle through it. Influenza, is the closest representative for this. Every year, influenza is here. I'm not saying that COVID-19 will always be here every year, but I certainly think we will probably be looking at vaccinations that are dual vaccines for influenza and COVID-19, and strategies may change in terms of how we vaccinate. And it's a question of what new vaccines may become available. We have the mRNA vaccines, Moderna and Pfizer, and we had Johnson & Johnson. But then that doesn't mean that that's all there is. Novavax is a vaccine that I've been tracking for some time, and their corporate office is actually in Rockville, Maryland. And it has been passed around through different physician and research groups that it's kind of the holy grail. The issue is that as it is in times of profit, that there may be special interests that promote their product and market shares, but Novavax is already being used in other countries with fantastic results, and the hope is that it will eventually become available here in the U.S. It had been slated to be brought sooner. Unfortunately, powers that be, it just hasn't happened, but it is used in other countries. But the other part of this is also with regards to medications. Now, influenza, we have an antiviral, Tamiflu, which is highly effective if it's taken in the appropriate period of time. And this is where we need to start thinking about this long-term strategies, is the sooner we identify an infection like COVID-19 and treat it, the better. because it is very often, just like influenza, if there's anything that delays detection that to determine that this is actually COVID, then the opportunity is missed. And I'll say this because routinely throughout this winter season when we had Omicron here, we had people who were testing and had symptoms, viral symptoms, and were told you're COVID-19 negative. It's great. Okay, but why do I feel like this? Well, people forgot about influenza. So when people were going and getting tested for COVID-19, they were not getting tested at the same time, which I think ethically was wrong. They should have, it should have been a combination test because we already knew influenza was here. And with influenza, Tamiflu, if taken early enough, within 12 hours of taking it, if you can quickly treat, then it is a miracle drug, in my opinion. I mean, it will significantly reduce symptoms, certainly reduce hospitalizations and fatalities. We have antivirals beginning to roll out. They are, have actually provided prescriptions for this antiviral for patients who are actively infected. But again, the decision part was, well, when did you have your symptoms? If it was 5 days ago, guess what? Antiviral isn't going to work. Maybe your vaccine and you still have antibodies. That's great. That's the best. But just like Tamiflu, you have a window in which to give it, and if you miss that, then so that begs the question of testing. If we are doing testing on people who are symptomatic, and we do it quickly as soon as symptoms develop, and we determine, okay, this is influenza, treat with Tamiflu. If this is COVID-19, the antiviral for COVID-19. But it's just trying to tease out how to get the testing. That even in DC to get the rapid antigen testing was a long line around Lafayette Park. I remember driving by and just like, holy cow, how are we going to get through this? But thankfully, Omicron, because of vaccinations, Omicron's impact and its duration was dramatically different from Delta. Why that is, it got here quick, and it seems to have been, seems to be leaving quicker too. But who's to say that, where we are in a couple of months in terms of another variant? So as we see these things evolve, it is being mindful of, those who have symptoms, immediately test, and then test not just for Omicron, but influenza if it's appropriate. And then more importantly, the treatment has to start promptly. We shift over to the vaccinations. The vaccinations, the big question now is every vaccine that's given, the intention is to turn on the body's immune system. And in turning on the body's immune system, we are looking at our natural defense. And really the one that we hope for the most for these vaccinations is the production of antibodies. And the reason we want antibodies is because they act as sponges. As soon as any virus enters into circulation, the antibody is already there. It will literally sponge up the virus. And that means that, the virus is not able to get a foothold. And more importantly, even if it were to replicate, as soon as new virus is made, that too is taken up by the antibodies. As we pass through where the antibody response is reduced, then it's this question of boosters. And so here's already the question of, we've already taken the 2 mandatory shots and some have had the booster. Now we're looking at questions about the 4th booster, if you will. It does beg the question of where are we at now in terms of the pandemic? And some research substantiates the need for an additional booster. I'm still on the fence about the 4th booster now for those who are not immunocompromised or not at greater risk. For those who received the vaccinations early on and then got a booster and that time is expired, then I think that's reasonable. But I don't think as a general rule, right now, I can fully support that. And I do think that as we have maybe another opportunity with vaccine like with Novavax, then we will have another tool to be able to combat this. Of course, with the antiviral, there will be more that will be available. There is limited supplies, but again, if tested appropriately, treated appropriately, I think we have a lot more than we certainly had this time last year for sure. So, for the variants themselves, the World Health Organization and others are constantly looking across the globe and to any new outbreaks. And there certainly is a lot of media with regards to COVID-19 and will continue for sure. But we do need to be mindful that if we hear of a new variant coming, that it may be premature. And we can in a sense be cognizant that we still take the same precautions. We put masks on, we wear gloves, we do hand washing. Those who are at greater risk, that I think is going to stay with us. I know that the city is looking March 1st to remove the mask mandate, and I actually support that. But I do think that people still need to have, and I think people will still have, this knee-jerk reflex of taking more precaution. This is very different from influenza, which had been around, forever with us. And when we compare the vaccination rate for influenza for what we had for COVID-19, dramatically different. And furthermore, when we look at 2020 and influenza's impact versus COVID-19, it was very clear when we were treating patients for influenza prior to COVID-19, we usually had 100 to 200 patients. In 2020, we had one influenza patient. So it tells you that there actually interventions do work, and we need to consider implementing or having at least some forethought about that. And so if a new variant comes, we'll have vaccinations protecting us, we'll have antivirals to protect us, and we will get through it. But I think every winter it's going to be a new challenge. Now, what this winter has been, I think we are thankfully out of the worst of it. I don't, for the discussion groups that I have with other scientists and physicians around the world, there isn't anything immediately coming, and that's a huge sigh of relief. It means I don't have to test, every day. I can go back to just practicing regular medicine. But I do think we are doing much better. And we may hear stories from other countries about new variants coming, but I would not jump to that. Maybe that might be oversensitive, trying to get viewership or ratings. Who knows? That's certainly an easy ploy. But I do want to take a moment. I do tend to ramble, but I just wanted to see if there were any initial questions, anything from those who are on now.
All right, thank you so much. Yes, and just a reminder, if you have any questions for Dr. Brown, go ahead and put them in the chat and we will get to those. And we have a few other things that we definitely want to touch base with everyone on too. One of the questions is there a specific time of year that we can expect a new variant, just like the flu comes around fall, winter?
Mm-hmm. Yeah, and so what's an interesting finding is we actually had influenza in the area in August, which is very early. So you can think that people who normally would get their vaccine in September, October, which was when the vaccine is available, we didn't even have the vaccine ready for influenza. So we were using Tamiflu quite a bit. And certainly those who we were testing, and it was we did a combined COVID-19 and influenza rapid kit, knowing that influenza was here, and we were able to treat people pretty quickly. I do think that this will fit, each. Just if we look at SARS or MERS, they have a life cycle, even influenza itself. I mean, when we look back at influenza, we usually get 3 different peaks of influenza outbreaks each year. And typically the vaccinations that are provided, which is, guessing what these changes are going to be, we usually see the vaccines lose their efficacy later in the winter, when people still have antibodies, but the vaccine is tailored to a virus that now is different. And I think we are more than likely going to need to do vaccination programs similar to influenza. And I'd be in favor of combination vaccines. I'd be in favor where you could give two separate vaccinations, but it's a question of how do you optimize a vaccine and also make it so that people will actually take it. The biggest problem with the influenza vaccine was the influenza vaccine originally, they had tried to design it so that you would get more than just one shot, but people wouldn't come back for the second shot. So, the human determinants were that, well, let's just give one vaccine at appropriate time so at least we can get some benefit from it. And I think whether we are going to need to do a combination and then maybe a booster, yet to be determined. But again, other vaccines are going to be coming, and we'll refine these over time. Novavax is a very encouraging one, and I would certainly urge everyone listening to do their due diligence and research on it, and hopefully it will become available as another option. I always am worried when I don't have options in terms of how I can provide treatment, and relying on mRNA vaccines only. I think certainly when I've seen reactions, I just want to know that, well, there's another option. So I'll stop there.
So in relation to Omicron, we just saw the big spike from the holidays come through. And now that things, like you said, are starting to settle down, thank goodness.
Mhm.
Is it possible, though, for Omicron to kind of rear its ugly head again? Is that possible? You think that you can reinfect yourself?
Well, yeah, they have talked about Omicron reinfections, and that certainly is a possibility. For those who have already had Omicron, you are essentially again boosted. You recovered from it, so you have antibodies. So you would think that if you had the same variant, then your antibodies are tuned in for it. So it does beg the question, if somebody is reinfected with Omicron, are they more likely to be asymptomatic but still transmittable? And this is where we go in from the testing for PCR, or polymerase chain reaction, which is a very highly sensitive test to detect for any genetic material, versus rapid antigen. The PCR testing is looking for any genetic material on any sample, whereas the rapid antigen is looking for a viable virus antigen. So what it means is that you could still test positive for COVID-19 by PCR, but you are not transmittable. And that's why really a shift, especially for trying to get back to normal, uh, certain activities like groups or going to an event or a social gathering, rapid antigen is going to be a better approach than PCR. First of all, because of the time factor
Mm.
and the cost factor too. But the rapid antigen allows you to quickly look at, and you have to think about numbers. When let's say you test 100 people for screening, and if you're looking for Omicron, let's say, then what's the percentage likelihood of a positive? Now, when people are symptomatic, the likelihood is much greater that they will, either test positive for COVID-19 or possibly influenza. But when they are asymptomatic, that's the problem, in terms of can we actually detect the virus, and is the virus going to be transmittable? It all fits in with the pattern that we've seen with COVID-19, how you pick up the virus, you're not immediately transmittable. But over time, as the virus locks into your machinery to basically replicate itself, then you have enough of the virus that it starts to shed, And that's where the rapid antigen testing is extremely important. And
That
we do that more and more now, and I'm actually more in favor of that for certain situations.
that comment actually dovetails really nicely into our next question, which is what is the data showing on the rates of false positives and
Mhm.
false negatives with testing?
So you have to go back for any test. There are inherent errors in the test itself, and we talk about things like sensitivity and specificity. But there's even more so errors in sampling, and so it's you have to think about at each point where an error can occur and whether you have a false negative, meaning that you actually have the virus but the test is negative, or false positive, which is that it's saying that you have the virus, but you actually don't have the virus. And it's tricky because for those who are vaccinated that have antibody, the antibody is sucking up the virus, right? So like a sponge. And you have to think that, if that's the case, you could test one day and be negative and be positive the next day and then be negative the next day. And I've seen it. And then it's just like, what are we going to do? This is insane. And we've done it confirmation for rapid antigen, and we also did it for PCR. So it's a question of how do we do the interplay between the testing, false positives, false negatives, and what we already know we're doing to combat it, which is the use of vaccinations. And here's the other part of it is once we start adding monoclonal treatment or antiviral treatment, then even more so, we are having a direct impact or influence on the results that are obtained. So if somebody is positive, they need to be retested. There's no question. The concern is how was the testing performed? Was this performed, at a facility where there was a lot of testing going on? Because that begs the question: is there inherent error in whatever facility is doing the testing? And we've seen that. We've seen where, unfortunately, samples were contaminated, and unfortunately, it came back as positive and then retested, and it was established, and it came back ultimately that the testing center was not doing the appropriate precautions to prevent false positives. And the opposite, which is false negative, where, unfortunately, we've had situations where samples were collected and not properly stored and laying around and eventually tested. And guess what? Sample's no good to be tested anymore. That would potentially lead to a false negative when somebody actually has the virus. So I do think testing is a conundrum because, you do have to provide testing. But how is that testing fit in with our strategies that we already currently are using to combat the pandemic, and then more moving forward as well? There, believe me, we are looking at different ways to do testing. Everybody knows about rapid antigen and the PCR, but we are looking at other protein-based testing options, which would not only test for just one virus, but a multitude of viruses. But again, that's in development, and will we get there? The fascinating thing about all of this is it has really required a lot of attention where we needed it. I'll be honest, where we were with vaccine development prior to COVID-19, there really, there was certainly research funding, but with COVID-19, we've really gone all out on in exploring every possibility for vaccinations, and that's why Novavax and their technology for the vaccination is incredible because it's kind of the holy grail. And then we can start really looking beyond just COVID-19, but malaria and Lyme's. It just keeps going on. So there's always a silver lining. So I'll stop there.
You and I were talking beforehand a little bit about traveling, specifically international travel and the things that we need to do to be safe. Can you tell everyone a little bit more about that?
Yeah. So domestic travel, there isn't really any requirement in terms of testing. But international travel, there will have to be continued monitoring. In the UK and France, all that's required is rapid antigen, and I support that. And then you have other countries who are requiring can only accept the PCR, like UAE and other places, and I can accept that too. Uh, what I would hope is that as we, and when doing this international travel, it has to be done in a way that's coordinated well. So, testing sites at airports, that, it weaves into a process that's much more efficient, I think, will certainly help. Right now, the rapid antigen is self-administered. I think if we are going to continue to do PCR, we have to look at self-administration as well. Uh, it just purely because of the logistics for it, and also even for forward travelers, the appropriate testing, because if Omicron was brought here, it didn't originate here. So that's the important thing about international travel and these variants. We have to have the testing that gives us enough warning to be able to quickly come and do the appropriate steps to reduce spread. And if the testing doesn't fit with that, guess what? We're going to continue to suffer from these outbreaks, and we will continue in a pandemic as opposed to endemic. So, and that was very clear early on with Omicron for myself. My first case was, international client who came from the Pacific and then went to the UK, was in the UK, and then developed symptoms as they were arriving to the US. And they didn't actually get the results of their rapid antigen was negative when they were in the UK, and then positive when they arrived in the US. Fully vaccinated, everything was, and otherwise healthy. But because we had the information quickly, we were able to then find the appropriate space to quarantine for the required period of time and continue the testing. And more importantly, take those samples to NIH and get the testing to determine that it was Omicron. So I do think international travel and the testing that is being performed is going to be invaluable. I think any failure in testing for international travel is going to open up the doors for new variants. So we'll have to see where we are. There's no question. There's going to we've already seen a lot more international travel prior to Omicron coming, and now international travel decreased, and now we are coming back again. Particularly here in the Washington D.C. area, we have the cherry blossoms are going to be blooming in a minute, and when they do, guess what? We're going to get a lot of local travelers, but I'm sure we're going to have international travelers. And you can imagine everybody walking around, checking out the cherry blossoms is going to be a very interesting space. Because if you've never been to the cherry blossoms during their peak, it is a zoo. So it'll be interesting to see that. So if you are doing any international travel, I encourage you to find out the country where you're at, what the numbers are, what the vaccination requirements are, what's the documentation well in advance. And more importantly, they have their testing requirements, but you should have your own, for your own reassurance, what testing requirements you would want.
That's a great point. And as people are making those summer plans and those holiday plans, that's such a good point. Capital City Nurses, we are so parallel to the work that you do. We go into people's homes, we take care of your loved ones. We're very close hands-on contact. And I know that that's such a passion for you. COVID unfortunately derailed a lot of the medical community's work with people, but you have something that's really personal to you with Ernest Medicine, and I wanted to give you a chance to talk about that.
Yeah, no, absolutely. So for those who have known me, it's I'm always evolving and always try to not reinvent, but kind of as I'm getting older and supposedly wiser, thinking about the future. And part of that future is, as a physician, I came to this space by my own path, and I will continue down that path. But part of it is to also bring people along with me. It is very much a journey. And in that regard, we are launching a nonprofit. We will be shifting Doctors to You to be our services, medical services, to be our nonprofit, which then helps us to fund education, outreach, and also a docuseries called Ernest Medicine. Ernest Medicine is really about connections. It's about going out and finding the stories that connects us all. Why, as human species on this planet, our ability to connect with each other is, as we've seen with COVID-19, when we lose that connection, the impact is horrific. So we have to come back to our roots, and Earnest Medicine is about taking those journeys. We have a video podcast, and we have now, with the creation of our nonprofit, the ability to go out and do more production. So we'll be going around the country, picking up stories. But I'm born and raised in DC. I love DC. I love the stories here, and there's a ton of them. I would certainly want to share with us out with the group, so that if there's anyone interested in participating or has a story, we'd love to listen to it and see what we can do together. Because sharing these stories is how we're going to be able to. That's one of my patients calling me. That's how we keep moving forward. I think one of the biggest problems with COVID-19 was isolation. And, if we can, work together and on these stories and build something over time, it is, in a sense, a grassroots movement. And for myself as a physician, I'm not an entrepreneur. Doctors to You is a business, but not to me. It's not. It's a passion. And so, moving to the nonprofit is really to be able to then hand off the baton to younger physicians when my time is up. Right? I'm not going to sell this. This is not a viable business to buy or sell. So we are pivoting. And COVID-19 gave me much more insight into making some of these decisions. So, and I think we've been, one of my friends had set up a GoFundMe where we had certainly people supporting, but we are now going to be doing our medical services to fully support Humans for Healthcare, which is the nonprofit, and Ernest Medicine. So certainly we can share information on our series. It's just earnestmedicine.org. And also there's a place on YouTube where you can find our channel. And yeah, so again, this is, I'm at the point in my life that I want to be able to have purpose and meaning, and work with like-minded people to be able to do that. And certainly sharing that with Capital City Nurses and my other friends out there only makes sense.
Thank you so much. I appreciate that. And I love that you're setting things up for your legacy. And that's very similar to what our clients, they want to live and have a legacy, and we're there to help them do that comfortably in their home and keep them safe. And it's all about safety, and it's all about happiness at the end of the day, and love. So we are so happy that everyone was able to join us today. In the chat, I did put links to everything that Dr. Brown talked about with Ernest Medicine, his GoFundMe for that, and then of course a Capital City Nurses website. If you'd like more information about the services that we can provide and that we can offer, you can also call 301-685-7391 and speak with somebody if you have some really particular questions. We are there to answer those questions for you. And Dr. Brown, we've done this series now several times, and every time I learn so much. So thank you so much
Absolutely.
for giving us your time, and thank you so much for the work that you do.
Thank you.
And I know it means a lot to you, and it means a lot to us. So Really appreciate everyone joining us today. We will let you get on with your beautiful Wednesday afternoon. And thank you so much for joining us.
Absolute. Be
Have
well.
a good day. Bye bye.
Bye bye.